A very good evening to all our viewers who are joining us at Kopi with Vance. Yes, that's right. We have come to another segment of lifestyle show, but of course today is not going to be a lifestyle show. Today is the health topic. We just did a shift between the health topic and lifestyle today. So tomorrow will be the lifestyle show that we have, in fact, a talk session, not a show. But okay, thank you so much as usual. Before we start our talk session, there comes the coffee, right? That's why I call the Kopi with Vance. But today our biggest partner with Kopi Events, Forage. Hey, thank you, Dustin, for sending me the latte for today. So it's not coffee, it's coffee, right? Latte. Thank you so much. Cheers. As usual, we have started today. And if you look at today itself, the topic, it's going to be a very interesting topic. And my guest speaker coming in again for second time. I'm very excited and blessed to have him. We all should know who is he. Is of course Dr. Dinesh Nair, a cardiologist, a very famous cardiologist, very humble guy. Whenever I see him, I become very calm as well, because you can see he's very calm and very focused. So he's going to come up in a very very quick moment, all right? But before that, I'm just going to give little statistics. Cardiovascular disease is the leading cause of death globally, and we all know, right? And it's projected to remain so. It has been geographically, gender, or social economic boundaries, and every year we all know that heart disease and stroke causes as many deaths as HIV or AIDS or tuberculosis, malaria, and diabetes, plus all forms of cancers and chronic respiratory disease combined, right? If we don't take care of our body inwards, most of the time we take care outwards, but we tend to fail taking care inwards. So an estimation about 17.3 million people die from CVDs, all right, that is cardiovascular diseases in 2008, and representing 30% of global deaths. Of those deaths are an estimated of 7.3 million due to coronary heart diseases, and 6.2 million were due to stroke. By 2030, 23.3 million people would die from that's another topic, but cardiovascular diseases, mainly from heart disease and stroke. These are projected to remain the single leading cause of death. And thank you for the source from World Health Organizations. And most of the time we exercise, we eat healthy, we don't try to get stressed. But unfortunately, because of our lifestyle, we always tend to get all those things. Sometimes we eat unhealthy, sometimes we get stressed, and of course comes along with some bad habits like smoking and, so much of alcohol drinking. But today's topic is, of course, we're going to talk about the innovations in cardiology. And without any ado, I'm going to bring my guest speaker, Dr. Dinesh Nair. Hello, doctor.
Hi, Vance. How are you? Can you hear me?
I'm hearing you loud and clear, sir.
Fantastic. Thanks for having me on board again.
It's a second year for joining us at Kopi Events, Doc.
Yes.
And I got to say, despite your busy schedules and things that you do, and it's a great honor to have you back in the show itself.
No, it's my honor. I mean, I was just looking back. It was over a year ago that we did the last show. It was more of a chit-chat session. We sat down, we had coffee, and we answered a few questions. And there were no slides the last time. So this time, at your request, we put a few slides up, and we tried to think of a new topic. We called it Innovations in Cardiology. As you know, I'm an interventional I'm a cardiologist. I see general cardiology patients as well, but a lot of what I do is actually trying to open up arteries that are blocked, plumbing, if you will. So I'm going to show you some new innovations in the plumbing sphere of
Okay.
cardiology, where we fix arteries, and cardiology is a fantastic and rapidly growing aspect of medicine, where there are new innovations almost every day, new studies being published all the time, new techniques to fix arteries, and we've made a lot of difference to patients' lives and in saving patients' lives over the years as well. So I'm going to share some of these new things with you today, but we'll start out with a general introduction, if that's okay.
Okay.
Yeah. So are we ready to go, or do we?
Yes. Yes, doctor. I think we are ready to go. But before we go on, maybe you just want to do a quick introduction about yourself. I know you have done that last year, and we have our posters
Sure.
up, but we have new viewers as well, so probably they will get to know you better, doc.
Yeah. Okay. Well. Okay. I'm a cardiologist working out of Mount Elizabeth Novena Hospital primarily, but I'm registered in a few other hospitals here in Singapore, the Mount Elizabeth Orchard Hospital, Gleneagles, a few others. But the primary practice is in Mount E Novena. We see a wide variety of patients, mainly with cardiology related problems, mainly with cardiac problems. We see a lot of the worried well as well who come in for checkups to make sure that they don't have heart disease. We also know that like 50% of patients who have heart attacks never knew they had one. 50% of people who've got blocks in their heart arteries don't even know they've got any symptoms. And it's often found incidentally. So a lot of what we do is actually trying to preempt problems, make sure that we detect heart disease and other problems, other diseases as well, beforehand, and reduce the risk for the patient. So that's what we do on a daily basis. So I'm third generation Singaporean, have worked in a few countries around the world, came back to Singapore in 2001. That's about 20 years ago. And I've been practicing cardiology in Singapore since then. I was doing cardiology in England prior to that before I came back. That's pretty much me in a nutshell.
Thank you so much, doctor, as the humble introduction you always do. But before we even start up, I always like to say that that angels in the form of doctors, because they are so much of human beings, they are trying to rescue or help and assist the human beings. So thank you so much, doctor, for coming on board with Kopi Events. Thank you, doctor.
That's very kind of you. Thank you, Vance. Thank you so much.
Thank you,
So
doctor.
perhaps what I'll do, yes, is
Please
perhaps
go ahead.
start sharing the slides while we continue talking, because
Yes, doctor. Let's do that.
that's
Okay,
always
viewers
the most difficult part.
Mhm. So viewers who are watching this, please do share and like it. Sorry, it's iced in there. Thanks, Dustin, for putting the ice. I saw your slide, doc. Okay, there is it.
Okay, great, it works. I always struggle with this part of it.
Okay.
Computers weren't around when I was in school, so I was born in the late 60s. So I've been struggling with it ever since.
Okay.
So my topic today, a
Okay.
little different from previous topics that I've presented, is innovations in cardiology.
Mhm.
As you can see, I'm at Mount Elizabeth Novena Hospital, and I've worked in a few places around the world based on the countries you see below there.
Mhm.
This is how you can contact us if you wish to. There are other talks by us on YouTube channel that you can look up our name and you'll actually see them. Some in different languages. For those of you who might be from Indonesia, there are a few talks in Bahasa Indonesia as well.
Okay, doc.
So this is where we work, Mount Elizabeth Hospital, Novena, the newer one of the two. But we also have a practice out of Mount Elizabeth and Orchard. So
Okay.
let's start out basically
Okay, doc.
with basic anatomy. Everyone's heart sits like this in your chest, okay? And there are arteries sitting on top. If you look at the cursor here, and I hope you can see the cursor, these are arteries coming out of the aorta. So the heart pumps blood out to itself and to the rest of the body as well. So the heart is the most important organ. Well, people might say the brain, but if the heart stops, everything stops. The heart is the most important organ because it keeps everything alive. If you took a cross section of the arteries, if you can see my cursor here as well, and I hope you can see the cursor,
Okay.
there's the yellow bits here are the cholesterol buildup in the arteries. If you've got blocks in your heart arteries, which are here, providing blood to the heart muscle, or if you've blocks in the neck arteries going up towards your head here, providing blood supply to the brain. And if these blocks become significant, you get a lack of blood supply and a reduction in blood flow. So the worst case scenario of a block here in the heart arteries is a heart attack, of course. Worst case scenario up here is a brain attack. Once cholesterol plaque builds up, that plaque will always, it's like plaque in your teeth. We call them cholesterol plaque, blockage, atherosclerosis, arteriosclerosis. There's a whole load of names for them, but it all means basically the same thing. There's a lump of fat or cholesterol on the inside of the artery growing. Once it's there, it never goes away, even if you take medicines. And once it grows, it starts growing at an alarmingly fast rate unless you slow it down with medication, which we'll talk about later on.
Okay.
So once again, most patients who have heart attacks actually don't even know they've had one. 50% of patients, there's been a study that showed that. The worst case scenario, if your heart artery is blocked off here, is a heart attack. Only a certain number of people actually get symptoms from it. If you've got a big block up here, once again, brain attack or stroke, and many patients actually walk around with mini strokes without actually having known it. So what we try to do is screen for this beforehand. What we tend to do a lot of the time, before we even start medicines, if we find that people have risk factors, to try to address them beforehand as well. Smoking, high blood pressure, high cholesterol, diabetes, sedentary lifestyle, genetic stress, and also obstructive sleep apnea, where your airway is blocked when you're sleeping at night and breathe. All these things, if they are corrected, can reduce your risk of having a heart attack, a stroke. You can see my slides clearly, can you?
Yes, doc. But I need you to click on the slides for me, please.
Oh, it's not moving forward, is it?
Yeah. Yep. That's right.
Ah, that's what's happening. Because I'm trying to use the left and right, and it doesn't go
Okay.
into that. So we have to click on the slides.
That's right, doc.
Okay, now I understand. Okay, so you can see a slide in front of you saying symptoms.
Yes, that's right, doc. I can see that.
Okay, this is going to be a problem like this because it's not in PowerPoint mode. It has to be like this. So if I click, I'm sorry, I'm just trying to get this right.
No problem. I think this is fine also, doc. I can see it very big and clear as well. I'm sure the viewer as well also.
Mm. Yeah, full screen, it doesn't move. Oh,
Okay.
it doesn't. That means how do we play our videos? Okay, no problem. Because
Okay.
somehow in the link, this is what's happening.
All right, doc. Okay.
Because it's going on real time on the other one. Okay,
Okay.
so I'm going back to symptoms. It doesn't move.
Now we're looking at the symptoms, doc.
Okay, so we'll
The
start
column.
once again. My apologies.
Okay.
See, I told you this is the most difficult part, actually, trying to manage the technology. So symptoms such as nausea, fatigue,
Okay.
chest pain, lightheadedness, shortness of breath, all these things can be signs of heart disease or heart attack. Heart attack is when there's complete occlusion of the artery, causing
Okay.
death of the heart muscle. But some of these symptoms, you can get them in a milder scale if you have blockages and you haven't had a heart attack. And they're warning signs. And these are some of them, and many people will be aware of these. No, it doesn't move to the next one.
So now
Okay,
we're seeing the diagnostic testing.
diagnostic testing. Okay,
Yep.
so
Yep.
then it works. Okay, so many tests can be done, such as an ECG, an ultrasound of the heart, echo, X-rays, treadmills, and different types of scans, such as a PET scan, nuclear scan, CT scans, and of course the gold standard to diagnose blocks in the heart arteries, an angiogram or angioplasty. I'll go into what that is a little later on.
Okay.
The inside of the heart, okay, has got 4 chambers. This that you see on top here is an echo. It doesn't play. I think I'll have to toggle back and forth between these two, so don't worry. Okay,
No
so
problem.
the inside of the heart's got 4 chambers, and we look at the heart pump and function when we do an ultrasound.
Okay.
When we scan the neck arteries, we can often see if there are blocks in the neck arteries as well. Now, if you've got blocks here, I'd mentioned the likelihood of blocks in your heart arteries are a lot higher as well.
Mm-hmm.
So this is what an ultrasound of the carotid arteries looks like, and an ultrasound of the heart called an echo looks like this. If we feel that there are blocks in the heart arteries, we can do a CT scan of the heart. A CT scan of the heart arteries, and you can see a slide here saying CT coronary angiogram. Yes,
Yep, we do,
you
Doc.
can see. Okay, good. So what you have on the left-hand side is normal arteries. What you have on the right-hand side is someone with a block. What you can see is blood filling the inside of the artery because we inject contrast. The contrast goes through the artery down, and here the contrast is pinched, or rather, only has a trickle of flow going down because there's a block here. So if someone has a block like this, the first order of business is getting them on the right medication to prevent that block getting bigger, to prevent that block becoming a heart attack, which is sudden occlusion of the whole artery, 100% blocked, and then opening it up as needed. There are several ways of doing that. In the old days, if you talk about 40, 50 years ago, we didn't have the medication we have now. We didn't have the technology. People with heart attack were asked to rest in bed for 6 weeks.
Yep.
As time went on, in the 1970s and 60s, towards the end of the 60s, there was bypass surgery. By the time we hit the 1980s, there was a possibility of ballooning and stenting. I'm going to show you all that later on as well.
Sure, Doc. We can do that.
This is what a coronary angiogram looks like. Okay, when you pass a catheter in and inject contrast into the artery, this is what a clean artery looks like. This is what a block in the arteries looks like. So if you had a block like this, there's several ways of fixing it. First of all, as I mentioned, medication. Medication is the mainstay of treatment. You can do ballooning and stenting. And as I mentioned earlier, bypass surgery. So bear with me. We're trying to find a way to manage this. So the only way this seems to be translating into going forward is for me to click on the individual slides. So bear with me. Apologies to the audience. I also mentioned that in the early days, the only way you had before the 1980s was bypass surgery. You've all heard about people having open heart surgery, taking grafts from inside, from the legs, sticking it on board, and basically bypassing the artery. That's what you do. But in the 1980s, a very interesting gentleman called Andreas Grunzig, okay, in the late 70s actually, developed a technology called ballooning without stenting. So 1980s, we had ballooning. 1990s, stents were invented. In the year 2000, we had better stents, which had medication on them, allowing this medicine to go into the arteries and prevent reblockages. In the 2010s, we actually had bioabsorbable stents. And in 2020, we have new technology that I'm going to show you in a short while as well. So we do all these procedures of ballooning and stenting in a cath lab that looks something like this.
Okay.
The patient lies down here. We have a lot of imaging equipment, and we can see what the arteries look like by rotating this arm around. So that's what an angiogram is like. Angioplasty is where we put in wires, put in balloons, and open up the arteries. So a coronary angiogram looks like this, and I don't know if we can play this.
Yes, Doc, it's playing.
So that's a block, okay?
Okay.
So when we want to do ballooning and stenting, what we do is we pass a catheter up this, through, into the artery, which you can see here, and then open it up with the balloon. So this is somebody who's had a heart attack. The normal artery should look like this, like a C shape around here.
Mm-hmm.
We pass a wire down, we pass a balloon, we open it up, and then once that's done, the artery is opened up. But unfortunately, for most arteries, what happens is it's elastic and there's often recoil of the artery. When there's recoil, we often need a stent, which is like a scaffold holding it open. So after you put a stent in, this is what it looks like: a stent opening up the artery and keeping it open. The problem with the stent is that it is a rigid piece of metal, like a pipe. So one of the new technologies we're going to talk about is where we allow the pipe to move with the artery. And I'll talk to you about that a little later on. So this is how we open up arteries. And once that stent is inside, what we do see and it should be saying drug-eluting stent right now, we do see is a stent sitting on the inside. We've pushed the cholesterol plaque to the outside and provided a new passageway for the artery, new passageway for the blood to go through to the heart muscle. This is how we do ballooning and stenting. Many people and many in the audience would have heard of all this. And the new technology that we're going to talk about is how we can improve the interventions that we have, how we can improve the procedures to get better outcomes. So this is what a stent looks like against someone's finger. You can see it's really, really small. So
I
this,
think, Doc, is it just a thumb size, yeah?
this is someone's first finger.
First
So
finger. Okay.
it's even smaller. A lot of the stents are 2 to 3 millimeters in diameter, 3 to 4 maximum, and with lengths of about 20, 30 millimeters or 2 or 3 centimeters. And that's really, really small. So this is what the stents look like. Now, I talked about new technology. So there's a few new things that we have incorporated into our practice here in Singapore, in a few of the hospitals here, not all, and especially in our practice, for patients who come in whose blood pressure's in their boots, the heart is practically stopped, the procedure becomes very difficult, the risk is very high. We have certain devices which we can put in at the same time that we do the ballooning and stenting to offload some of the work of the heart. And one of these devices is the impeller device. And this is something that we've recently been using in cardiology. So in the past, if patients' blood pressures dropped down to 20, 30 millimeters mercury, extremely low, they were unable to do ballooning and stenting for them because the patient wouldn't survive. What this does, this device, is it goes in and offloads the heart and maintains the blood flow to the rest of the body while we're trying to open up the arteries. In the old days, all we had was balloons that we could put in, which were not that effective. We used to bypass the heart in the way, meaning get part of the blood out into a system and pump it back in to support it. But now we have this kind of a device that we can put into the heart muscle, pull the blood out. I don't know if you can see my cursor, pull the blood out and pump it back in. So this is an impeller device. If I was able to do a normal PowerPoint, I'd be able to show this to you a lot more easily, but unfortunately, we've had to improvise this time around. This is what the impeller looks like. It's a very small device going up. I hope you can see. You can see a device going up into the heart. Yeah, Vance?
Yes, Doc, I can.
Fantastic. And what it does is, you see that little thing? We actually call that a pigtail, by the way, just it looks like a little tail. It sucks up the blood and pumps it out and lets the heart rest while we're doing this. So high-risk patients who are told in the past that the chances of them surviving are less than 10%, okay, now have a higher chance of surviving of 50, 60, 70% even, or even higher with this kind of a device. So we've been using some of this. The experience, admittedly, is relatively new, but we have been using a few of these in Singapore now with very good results. So what we tend to do then, and this is what it looks like, inside the heart while we do ballooning and stenting. And it's been shown to improve survival significantly. Another device that I'd like to go into, apart from this impeller device, is a robotically assisted procedure. We have been using a robot, and I know everyone expects that we're going to have a robot sitting there and doing the procedure for you, but what we have is a robot arm that goes in, does a bit of the work for us, makes the procedure a lot more precise. And this is what that robot arm does. So we've been doing quite a few of these cases recently, only out of 2 hospitals in Singapore, our hospital in Mount Elizabeth Novena and in Tan Tock Seng Hospital, where I've thankfully had the privilege of doing cases in both. This kind of a robot arm that goes in. And what we found is that we can improve outcomes for everybody. So this is the first slide here and shows you the innovations that have been going on from 1977 till today. This is Andreas Grunzig, the guy who did the first angioplasty. We used to do normal ballooning and stenting like this. And now we can have the operator sitting at a console and robotically moving a joystick to get the procedure done, to get the devices into the patient's heart and moving it. So this is what it looks like. Someone like me would sit here and be able to do the procedure, reducing radiation to ourselves, but also making the procedure a lot more precise. So in the past, the doctor only had to use his hands at the bedside. Now we can use the robot arm, and you can see that here. Yes, Vance?
Yes, I do.
That's an arm sitting there, passing the catheter up and injecting contrast into the patient's arteries, passing wires, passing balloons, and allowing the procedure to be done more precisely.
Doc,
This,
sorry, Doc. I just gonna ask you this. This seems like I don't know. The way I look at it, it's like sitting and playing like a computer game. It's
yeah,
so advanced. The technology is just amazing.
yeah. So we've done a few of these cases, quite a few of these cases here in Singapore. It is like playing a computer game, and there is a joystick, and I'm going to show that to you in a short while. What the
Okay.
joystick looks like. Okay, this is what the robot arm looks like. I'm going to reduce the volume on this thing.
Okay.
There's no volume. Good. Okay, so it goes like this, and I'll actually fast forward it a little bit because this is quite boring. And what you actually see is an operator like myself gaining access to the patient, passing catheters in, and then we have an assistant like this coming in, attaching the device, allowing us to connect all the pieces together, and then we can move away from the patient, look at things on a console, and using a joystick and small buttons to move things back and forth, allowing us to do the procedure more precisely. I'm going to fast forward a little bit on this because on a normal slide, I wouldn't be able to do that, but I can do that here.
Sure, Doc. Sure.
Going all the way up to here, bear with me. And this is what it would be like. You can see a little joystick here, a couple of joysticks. We can move balloons, we can move wires, and we can visualize it and measure it to very precise fractions of a millimeter movement back and forth. So this actually exists. I know it sounds really futuristic, but this actually exists at the present time. And we are actually moving towards using AI to be able to improve the outcomes on this as well. Artificial intelligence has been put into a lot of these devices as well to allow better and more accurate angioplasty. And what it also allows us to do is to be able to do these procedures remotely. So if you look at the slide, this is what we are doing here right now. And there's no need for us to do this in Singapore remotely because everything is really close. But if you were in the outback in Australia, perhaps, or in some other country, perhaps, where there's hundreds of kilometers from one place to another,
Right.
you could have one operator sitting here, another one on the other side, putting the stuff in, and you could move it theoretically. Now, it is no longer theoretical because here, 8 feet from the patient, hardwired procedure is being done. Then after that, the first procedure was done from a different room where you couldn't directly visualize the patient, but use the video. 200 feet. And one of the doctors in India, Dr. Tejas Patel, actually did a procedure, the first procedure remotely, 20 miles from the patient, using an internet connection. That's pretty cool, no? So these are the things that we can actually do now. I talked about ballooning, talked about stenting, and it seems like it's fantastic, but there's so many other technologies that are coming to the fore, such as this one, allowing us to do things even remotely. What it does do is also reduce the risk for the procedurist, such as the physician and the nurses. Because what a lot of people don't realize is the amount of radiation. Let's say if I've done a few thousand angiograms and angioplasties by now. Each time I do that, it's like as if I'm getting one CT scan for myself. So what this also does is it reduces the risk for the person doing the procedure, the people assisting it, and even for the patient, reducing radiation risk altogether. Admittedly, the radiation risk is not that high, but any amount of reduction in risk is useful. So this is me doing one of the procedures. I don't think we need to play this slide. We'll move on.
Okay.
But what I will show you is how we move. This is me moving one of the joysticks. The whole thing is draped. What you see here is us visualizing the artery, passing a catheter in, using this to pass balloons and stents. You can see my cursor, yes?
Yep, I do.
Yep. Passing balloons and stents going down and delivering the balloon in with very precise calculated movements. So what you'll see is this is a catheter, this is the artery, and we get the balloon, move it all the way down, put in the right spot, and open up the balloon. So for this patient, we actually did this. There was a block here. We put a stent from here all the way down to here, and you can see the artery is a lot bigger. This is a catheter, contrast, injected into the catheter, down the artery, down this way, and that's what a block looks like if it's pinched. What you see is a pinching of the flow. So for this patient, that's how we did it. That was the first robotic patient that we did in this hospital. Now, this is not where the technology ends. I'm just going to show you 3 or 4 new cool technologies. Very often you've heard of patients where they've been told you can't balloon or stent the artery. Bypass is going to be very difficult. And a lot of the time, bypass surgery is not really needed for a lot of patients. And the reason for that is the arteries are really calcified. So what I'm going to go through as a next interesting innovative technology is shockwave intravascular lithotripsy. This actually has taken technology. You've heard about people blasting kidney stones, right? Using sound waves. You've heard of people blasting gallstones using sound waves. The same thing can be done for calcium in the arteries. Calcium builds when the cholesterol or the soft cholesterol plaque sticks against the inside of the vessel wall. And over time, what your body does is it deposits calcium on top of it to harden it. When it hardens, initially, it keeps it safe. But when that hardened calcium becomes bigger and bigger, it causes an obstruction to the blood flow. And very often, when you try to balloon it, you can't balloon it. So this is shockwave intravascular lithotripsy. This is an artery, contrast being injected down the artery, going through. This is what blocks in the heart arteries look like. And if you look here in the center where my cursor is, you will see that this area is narrow and there's a whole load of calcium. We can't get devices down. You see many patients where they had a failed procedure as a result of this. What we've done in the past is when a balloon goes up, I don't know if you can see this, this should be one smooth oval, but the balloon can't go up here because of calcium. What we've done in the past is use drilling devices, like you drill to go in. It's called rotational atherectomy, rotablator. But sometimes that comes with a risk as well. For many patients, we may not necessarily need to use this device, but we can use this device on the right, where we pass the catheter in and we blast the calcium. It is safe because we know there's 30 years of safety data in blasting kidney stones. The soft tissue is not affected and only the calcified heart tissue is affected. We use this device, and this is how such a procedure would look. I'm also going to fast forward this a little bit to show you the device and how we put a balloon up inside the artery. This is actually a model where there's supposed to be calcium. You put a balloon up inside the artery, it emits these sound waves. And what they do is they actually break the stones or break the calcium sitting in the arteries. This is something that we were not able to do until recently. And we've started using this technology in Singapore for over a year now with some very good success. It isn't available everywhere else. There are a few colleagues of mine from different countries who have been waiting for this to come to their country to be able to use it. What you have is a pulse that's emitted right through, all the way into the artery. This is what your block looks like. That white stuff is the calcium. And what you get is emission of these shock waves going through, and it starts to break up this and allow it to be ballooned open. So this is one of the new devices that we've been using here in our practice with some very good results. I know a lot of this sounds very technical, and I know we have people of varying experiences in the medical sphere. There are those of you who've probably had this procedure by now, or family members who've had this procedure and understand this a little bit better. There are many who've done science as part of their education. Some people may be doctors, nurses, paramedical, scientists. Engineers understand this very well as well. But there are also many people out there who've not got the same background in biology, and some of this may sound quite technical. So I'm trying to simplify it as much as I can. And if needed, we can go back and discuss this if there are any questions.
Okay.
But passing a balloon down and cracking the calcium allows us to put a stent in. Remember, I mentioned you need a stent, provide a scaffold to hold the artery open once you've managed to open it up. So very often we can't open up arteries because the arteries are too calcified. I hope that explains it. Any
Yes,
questions,
no,
Vance?
okay.
This
I mean,
quite clear?
even for myself now, as I look at it, it's a bit of new thing, because always we know this angio is the very most commonly used, but right now it looks like the technology is just improving day by day, month by month, year by year. So I think it's really a eye opener for a lot of viewers, even for myself as well, to understand what is happening behind the scenes, especially.
Yes. So many people actually would have heard all this before, but you've not seen the new technology coming up. You've not seen the new advances that we have available that actually will allow us to improve outcomes, to improve lifespan of patients as well. So the last thing I'm going to show you
Okay, no.
is, and I think I can fast forward this a little bit to show you, it's a special stent that allows us to stent the thing, hold the artery open, but then at some point it has little links in the center. And these links have a bioabsorbable layer, a layer that absorbs and becomes a moving link. And what you have is the ability for the stent to move with the vessel. This is something very new. We've been implanting a few of these stents inside, because a stent is always a caged piece of metal that holds everything open. I was going to show you a video of this, and I'll show it to you
Okay.
when I get to it at some point, which is here. What you see for normal stents is you pass a piece of metal over a balloon, you pop it open, the stent is held open, ballooning and stenting. We've heard of this many times. The stent is held open inside the artery, inside the vessel like this. This is a normal stent over a balloon being opened up inside the vessel. And what happens is, you can see on top here, the vessel moves, and then below there, the vessel moves. But where the stent is, the whole thing doesn't move. Over time, it heals, and it's good. But some of the problems that we faced with this in the past is that because it doesn't move with an elastic tissue, the reblockage rates can be slightly higher. So with this new technology, you have multiple links inside here, like this, that dissolve over time. And what happens when you compare the new one with the old one, and you'll see a picture of this side by side, bear with me, is this guy. I don't know if you can see it. It's pulsating and moving with the vessel compared to the other one that didn't move at all. So we've
So, Doc,
been,
sorry, Doc, it sounds more like a suspension, yeah?
yeah, perhaps, yes. And it's all about trying to follow the natural motion of the vessel with the newer technology that we have. I would have, if my PowerPoint had worked a little bit better, I might have been able to show it to you slightly differently. I hope we've managed to do it as well as we can in the time allowed to us. And I hope this has been clear enough as well. But I also would like to highlight what I'd discussed earlier, is that in the early days, all we had was ballooning, that's POBA. We had bare metal stents where the reblockage rate was about 30% to 50%. We had better stents, such as drug-eluting stents. And as time has gone on, this was in the 1980s, 1990s, 2000s, 2010, and by 2020, we've got newer and better devices. And believe me, cardiology is so rapidly advancing that there are always new technologies coming to the fore almost every day. And in the next 6 months, maybe even 6 years, you're going to see so many new advancements that are going to improve outcomes for everybody. So what I discussed was basic risk factors, how blockages occur, how we can balloon and stent to open up arteries. You can consider bypass surgery, but that is needed for a lower number of patients as we move along and the technology gets better. I also discussed a few new technologies that allow patients in shock where the blood pressure drops into the boots, and we could previously not address ballooning and stenting for them, but we can now. How we're using new robotic technology to improve outcomes for patients overall with more accurate stenting, more accurate measurement of the blocks, and implanting of stents, um, new devices that can break up calcium, and also new types of stents, which we've discussed here as well, which should, in due course, give us better outcomes overall. So that is my talk on new innovations in cardiology, and I'd like to thank everybody for listening to me.
Thank you, doctor. So now we can remove the slide away. Thank you.
Okay, let's try and remove that, and maybe we can have a chit chat.
Yes, we do, because we have a couple of questions that came in, so we can actually address to that.
Okay, I'm not sure if I
So
can
I
see
mean,
the questions, but
I mean, doctor. I mean, for my take, I think. I mean, I always know how this NGO works. I mean, in terms of the procedure, but what you have just discussed today, wow, it's mind blowing. I mean, thanks to all the scientists and cardiologists coming up with that, the way of it moves around, for durability and what you
yes.
actually explain. I mean, it's quite an amazing thing to see that in the medical field, that always things are evolving. What we saw 2 years or 3 years back may not be necessary what we see right now. It's always changing, and something new always been evolving in this area of health. And I mean, mainly more on health itself.
Yeah, seems a bit like science fiction, doesn't it?
Yes, doc. Doctor, we have a few questions that came in, so probably I'll taking the first one. The first one is, of course, what are the signs of an unhealthy heart?
Yeah.
Of
So
course, love sick is not involved here.
okay, so we're trying to talk about heart as in heart disease as opposed to affairs of the heart. Yes. So
Yep.
we mentioned symptoms, but we also know that many patients don't get symptoms. So people always ask me, what are the first signs? You don't get signs of blockages in your heart arteries until the blocks are 70%. By the time they cause symptoms or they show signs elsewhere, it's usually too late. That doesn't mean you shouldn't look out for them, because when you've got these symptoms or signs, you need to see a healthcare professional. It can be your GP at the first instance, and then, of course, your cardiologist is needed, or you can go straight to the cardiologist, the way it works around here in Singapore and in a few other countries as well. But we mentioned in that first slide that if you're breathless, if you found that your exercise capacity has been reduced suddenly without any good reason, okay, if you've gained 20 pounds or 20, still talking pounds, 10 kilograms
Regular.
in the last 1 year, and you find that you're unable to climb up the same number of stairs, then you know that that is your weight. But if you've been relatively normal and you suddenly find that your exercise capacity is limited, you're getting pain in the chest, you're getting palpitations, you're sweating excessively when you do minimal activity, then these are signs that your heart may be unhealthy. Now, granted, there is the possibility that these may be from other reasons. Lung problems can make you breathless. If you've got issues with your thyroid gland and your thyroid gland's underactive, you might feel that you're tired. If your thyroid gland is overactive, you might get palpitations. So there are lots of possibilities, of course. But in the main, if you find that you're getting chest discomfort, exercise capacity is down, chest pain radiating up to your jaw or your arm in particular, these are signs of heart disease and an unhealthy heart to start with. Having said that, many patients have had heart attacks without any symptoms, and these are called silent heart attacks. Now, the strangest story of a patient that I ever treated was a lady who had continuous pain in her jaw, which she thought was a toothache. It was coming and going, coming and going. She'd gone and seen two dentists who told her that her teeth were fine. The third dentist said, look, this is not quite right. And by that time, perhaps the symptoms had gotten a little bit worse. He said, I think you need to go to the emergency department, get yourself an ECG. Very smart dentist, because this time it was jaw ache and she was really unwell with it. They went in there, and what she was having was a heart attack. on the ECG. So it doesn't always follow that you get normal symptoms when you're getting a heart attack. This lady was brought in, and I remember that I had to do angioplasty and stenting for one of her arteries. Many times people get what feels like gastric pain, and they think it's gastritis. And gastritis is often called heartburn because it seems to be coming from the heart area, which is in the center of your chest. All your nerves from your stomach, your heart, your neck, your muscles, they all sit in one area down here, unfortunately. And very often, all these symptoms and signs can be confused. And that is why, if you feel unwell or you have any suspicion at all, the best thing to do is once again consult a doctor, get as a minimum an ECG. I did see a question there that can an ECG pick up heart failure blockages? It can, if it is very severe. Early blocks, extremely unlikely that an ECG will pick it up, unfortunately. I
Thank you,
hope that
doctor.
explains that. That's another question that I saw pop up. Yes.
We have another one here. It's also by Melanie. Is it a heart attack on an anxiety? Because sometimes when people are too stressed, especially nowadays people are all working from home, so it can be very stationary, and probably they're working, but their heart rate can be like stage two or stage three, 160 over 80, diastolic, systolic. Beats can be like going up to 100 or 120 or 30. But at that point of time, I mean, they are sweating and they're going under tense motion. Could that also be lead to myocardial infarction, or we call it as heart attack? Could it be an
So,
anxiety?
it's kind of funny because one of the risk factors that we quoted earlier was stress. If you're prone to a lot of anxiety, your risk of getting a heart attack is obviously a lot higher. If you're prone to a lot of stress, your risk of getting heart related problems are significantly higher. The problem is, once again, there's this big overlap in terms of symptoms and signs. If it's the first time that you're getting this kind of symptoms, the likelihood is that it is more likely to be a heart related problem. If you feel constriction in your chest, palpitations, sweating like mad out of the blue without any reason, or if it's after unaccustomed exertion, or you're known to have high risk factors or significant risk factors. But if you're a 20 something year old person, no high cholesterol, and you've been getting anxiety attacks often enough, and this is not the first time that you've been getting it, then the likelihood is this is more likely to be an anxiety attack. Once again, I cannot give you a definite answer because if you're feeling unwell with this, you need to seek medical help first. Because the first thing the doctor can do is examine you, take a proper history, because everybody's story is slightly different. And if needed, and very often it will be needed, get an ECG done. When you do an ECG, if you're having a barn door bad heart attack, it is going to show on the ECG. But if you're getting a mild heart attack, very often ECGs don't show it. And that's when we admit patients to the hospital, very often overnight, or in the emergency department for a prolonged period of time if it's in a government hospital. You do blood tests to see if there's any heart muscle damage, because there's certain blood tests that you can do to look to see if the heart muscles become damaged. Those tests don't show up immediately, so very often you do it now, 4 hours later, 8 hours later, 12 hours later, even if needed, depending on the protocol in that particular hospital. And if those heart muscle enzymes are going up, it is a heart attack without changes in the ECG.
Wow. Good to
Okay,
know
so
that.
once again, there's no one answer for the whole thing. If in
I
doubt,
think
go and see a doctor.
so. As long as someone is not feeling well, I think it's better to call. I mean, not to call, immediately go to the hospital or check with a doctor. I mean, that's the best thing rather than calling a friend. I mean, for whatever the reason is.
Unless that friend is a doctor.
Oh yes, okay.
Okay.
Doctor. I mean, it's so much. It's something I am learning. I'm actually, if you notice that today, I'm actually speechless because compared to last year and this year, I think like wow. Even I myself, like, I mean, a bit of astonished because of the new procedures that been done and new way of identifying the new way of solutions. I think is so much on it. So which is, I think. So upskilling is very important, and also to in the health industry, I think is always evolving in terms of new things are coming up. Yeah.
Sure.
We have Kumar here. So he asks us, does your body warn you before a heart attack? So he wants to know the symptoms, like earlier symptoms, like prior to that. So uh,
Yeah.
hang on, Kumar. We try to get that answer for you.
Yeah. So I think we discussed that a little before. And I know this is something that really bothers a lot of people because they always want to know, is there a way I can preempt this? Right? Apart from going for a general checkup to start with, which is probably the best way to preempt it, to tell you the truth. Does your body warn you before a heart attack? Once again, it's the rule of 50s. 50% of the time it does. But the other 50% of the time, it actually doesn't. You get these symptoms, you might get milder symptoms of what could be an impending heart attack. You may feel particularly unwell, suddenly lethargic out of the blue, breathless, a little bit more than usual. Fair enough. That's your body warning you. But very often, the first symptom or sign a patient with a heart attack has, unfortunately, is the heart attack itself. And that's why regular checkups, checking your cholesterol, checking your sugar for diabetes is very important. An interesting thing about diabetics, if you've had diabetes for a prolonged period of time, you are considered a heart disease equivalent and are treated as if you have early heart disease to start with, even if you haven't done a check to prove it. Because diabetic patients need diabetic medications a lot of the time if the sugar cannot be controlled adequately. And if their cholesterol is high, they need to go on cholesterol tablets because diabetes is a heart disease equivalent. But what happens very interestingly for diabetic patients is the nerves become affected, and you may not be able to feel the pain of a heart attack. And that's why silent heart attacks occur more often in diabetic patients. So, once again, the warning signs are reduced in a diabetic patient. The warning signs are reduced in a more elderly patient where the nerves are not functioning as well as they should be. The warning signs are reduced in a sedentary patient who does not do much activity because then you don't know if you're getting symptoms when you exert yourself. And that's where the warning signs don't come in. And that's where we have to use other ways of checking, preempt the problem.
I think we can take another two more questions. So I've
Sure.
another one that is interesting here. This guy is from Sun Wong. I notice an increased need to urine at night. Am I at risk?
Okay, that's interesting because I'm sure there's stuff in the internet telling you that perhaps you've got a higher risk of heart disease if you need to urinate at night. And if you looked at the internet, you can Google just about every single drug and Google a similar side effect, and you'll probably pop up. But what you've mentioned, Sun, I guess your name is Sun, yes, um, is an increased need to urinate at night. Are you at risk? You might not be at risk of heart disease per se, but you might be at risk of other things. Urinating at night depends on your age to start with. If you're above 50 years of age, there's more than a 50% chance that you have a prostate problem. An enlarged prostate, prostate is a gland that sits in the urine tract and sometimes can block flow, and therefore people don't void completely and they keep needing to void in short spurts. The most likely thing for a man, and I guess Sun Wong is male. I'm hoping. If I got it wrong, I apologize. My apologies. It can be a prostate related problem. But sometimes needing to urinate at night may be a UTI, urinary tract infection. But the most important problem that you can face when you need to urinate at night is that you may also have diabetes because the need to frequently pass urine also occurs in diabetic patients. So you need to screen for this, sugars, your cholesterol. It depends on your age. If you're above 50 years of age, your risk is higher. Now, if you're 80 years of age, you've got an 80% risk of a prostate problem. So it depends on the age of the person as well. And then, of course, check for heart disease. So are you at increased risk? Have it checked with the doctor because you are now until you can exclude all these other risk factors.
Hope that has answered you, San Wong. Thank you so much. We have another one more question to take for doctor because it's almost coming to an hour of the talk session, as we usually keep it at maximum 1 hour. So this one
Sure.
is from Nisha. I got a message from her. It says what it feels like in an heart attack.
Yeah. So we had discussed this earlier as well. Thank you for asking Nisha again, because I may have gone through all this too quickly, and it's probably easier if I repeat some of these things. The classic symptoms of a heart attack, the classic symptoms are chest pain, radiating down your arm, up to your jaw, or to your back, associated with breathlessness, associated with profuse sweating. These are the classical symptoms. But once again, 50% of people don't get this. So if you get this kind of symptoms, you need to call a doctor or an ambulance, a 995, if it persists for quite a few minutes, immediately. But there are other people where the first symptom is actually fainting and collapsing when they get a heart attack. Because what's happened is the heart artery is blocked off, they've got an abnormal heart rhythm, they get palpitations, or they may not even feel it, and they may collapse. There's so many other possible scenarios. Sudden stopping of the heart may be the first thing that happens in a patient who has a heart attack. But once again, for the 50% who get classical symptoms, what I mentioned earlier was these symptoms, but lasting for a longer period of time. If you have chest pain that lasts for a few minutes and goes away, a few minutes and goes away, the chances of it being a heart attack are less. But if you have prolonged chest pain for 10 minutes, 15 minutes, 20 minutes or more and getting worse, that is very often a heart attack.
Thank you, doctor. Thank you so much. I think it's we have answered almost about 5 questions, and I think we are at almost done, and we have few viewers also already giving their comments as well. Thank you so much. Doctor, is there anything else you want to share with us before we call it a session today? Because I know this is your second time you're coming on board. The first time we talked everything about Q&A, and we had a very great chat about what is the procedures,
Sure.
symptoms, and sign. But today is something new on the new procedures that we talked about. That the waves thing that you use. What is it called, doctor? I mean that
Shockwave.
shock wave.
Shockwave. Yeah, it's
Can
basically
you
blasting stones like in a mine.
That's very interesting to see how the medical field, they're always evolving on that. But is there anything else you want to tell our viewers, doctor? I mean, in terms of taking care of the heart, especially no
Okay.
smoking or LT diets, exercise. I mean, all these we know, but if it's coming from you, then people will take it very seriously. Yeah, I guess. Yeah.
Yeah. So first of all, before I do that, I'd like to apologize to anybody who found this talk today too technical. We had done another session before, and for those who've already listened in to us, I figured it'd be useful if I shared something different this time around. I do realize after chatting with Vance that there's actually a lot of new viewers who are not there for our previous talks, but you might have heard previous talks from other doctors regarding heart disease on this show. And it is a show, it's a fantastic show, Vance, by the way. So
Thank you.
I apologize if some of it's a bit too technical, but I also wanted to highlight some of the technology that we have to deal with very complicated problems. So we live in a great age now where we have so much technology that we can treat things that were previously untreatable. But that doesn't mean that we shouldn't try to do the most basic thing and prevent these problems from cropping up in the beginning. A check to see if you've got genetically predisposed diseases such as diabetes, cholesterol, etc., at an early stage is very important. And if you find that you don't, that doesn't mean you're not going to have a risk of developing all these problems at some point. So maintaining that healthy lifestyle reduces your risk significantly. The problem that we have most of the time is that most people know, as you said, exactly what they need to do. They just don't want to do it. There may be many reasons, and I find that the most common reason people go, oh, I've got no time, I'm too busy at work, I've got kids to look after, etc. But we have to find the time somehow
Correct.
to take care of ourselves as well. Because if we don't take care of ourselves, we can't take care of the other people whom we care about as well. And you will prevent problems from occurring. You know, don't smoke. Of course, everybody knows this. How many people consciously decide to quit? Very few. Excess calories in food, excess alcohol. How many people who know about this actually truly do this? Very few once again, right? So the idea here is to do everything in moderation because, living a Spartan lifestyle is very difficult. It's very difficult for most people. But the easiest rule of thumb is to try to do everything in moderation, Don't do anything in excess. And try to keep your weight down. Try to keep your muscle to body fat ratio in a good zone if you could as well. And that's what people like Vance do for you, among other things. Try to make sure that you're healthy. And health is a holistic thing. It is not just about body health, how you look, how far you can run in a marathon, how much weight you can lift. It is a combination of things that includes mental health as well. And that's why a holistic approach is important, and moderation is important, as with everything in life.
Thank you, doctor. I
Thank
mean,
you.
that was a great, great advice. Of course, everybody knows what to do, but just that, time and workload and stress and all those stuff actually keep them in the base. But thank you so much, doctor. I mean, we have, in fact, I just noticed we have a lot of questions that came in another part of the Facebook, because we have shared this in three different segments, or
Okay.
three different tiers. But we have already been, because for viewers who want doctors to answer, you should actually be typing in the first live chat, which is a live Facebook, which is called Kopi Advance. But if you are sharing and messaging in other platforms, which is the same platform but just a bit different, the same branches, but then we will not get it. But anyway, thank you so much, doctor. We will. I mean, for me, I take it as a very valuable lesson to know that there's so much improvement. There's so much of technologies in the keeping the heart safe and safe alive. So thank you so much, doctor, for joining in the chat with Kopi Events on the innovations of cardiology. Thank you so much.
Thank you so much for having us on board today. I really appreciate it. Enjoyed it very much. Thank you
Thank you,
very much.
doctor.
And thanks
Thank you
everybody
so much.
for listening in.
Thank
Thank
you,
you.
doctor. So we'll catch up again very soon. Thank you.
Thank you. Thank you. Thank you.
Thank
Take
you.
care. Bye
Bye.
now. Bye.
All right, so thank you, viewers. In fact, that was a good 1 hour and 2 minutes of talk session by Dr. Dinesh Nair. Very humble doctor which I ever met. Down to earth, and if we can spend 1 hour, which is close to almost 10 p.m. right now, instead of just going back home to have a good rest, he take that point and that in him, to get that information out. So I really thank Dr. Dinesh Nair from my bottom of heart for joining at Kopi Events. And I know viewers has actually been sending a lot of messages in the other Facebook itself. So, but in Kopi Events, that's a main comment section that you show message. But if you message on that, apologize, which I probably right now I'm seeing right now. So there's a lot of messages that came in. Thank you, Ramesh, for saying super, Dr. Dinesh. Thanks for sharing. We have Aresh. Thank you, Aresh. You mentioned that it's a wonderful insight and understanding, and as well as Ashwin Siva. You also said that this is excellent. Thank you so much, Dr. Dinesh and Vance. I've heartened to know that there is so much of progress in the cardiology. Very useful for our friends and families. Thank you so much to all the viewers. I know the messages that came in the other part, but nonetheless, thank you so much that we want to talk about. But like today, I think I was pretty silent itself because I'm actually quite um, to know that in the health industry, especially in the heart, that so much of things are evolving. What we know that we thought we know, right now it's not, because there's always things evolving. There's always keep on learning, and that's why if you notice that doctors, right, their education never stops. They are just keep on learning and evolving time to time. Something new always coming up and improving on saving life as well, right? I mean, in Copy Events for the past 1 year, we've been talking a lot of topics, but I think that one topic that always catches my interest is about the heart, right? Being a CPR and AED instructor, my biggest worry is what happens if someone collapse and if I have to do, even though I got more than 15 years of experiences in CPR and AED, which some of y'all will do, but I think that we all have to be reskilled, as every 2 years our CPR and AED expires. We need to get skilled up again to make sure that we are able to do what needed while the medical assistance comes in. So I think that's very important. And I liked Dr. Dinesh Nair's advice on turning inwards. It's a very holistic. We can be very stressed at most of the time. In fact, all the time we are stressed. I think the only time we are not stressed is even when sleeping. Even when we talk about sleeping, very strange. Some can't even sleep as well because of stress. Because of stress, anxiety. You said your heart rate should be coming down to 60 and 70s. beats per minute. Probably in the bed you're thinking, and your heartbeat is like 110, 120, as if like you're running in a treadmill or exercising. I know we need to do a lot of stuffs, like turning inwards, which I really loved. Dr. Dinesh Nair's advices on, take care of ourselves. That's very important. In order for us to take care of our loved ones, I think turning inwards is very good. At least have 8 hours of sleep, drink lots of water. I mean, you can indulge in food. I mean, who doesn't? But there must be always a balance, right? When I talk about this in Kopi events, we always have the food segment that came in on the lifestyle. But then again, it's all in balance. We need to also spend a good time of exercises. Like what Dr. Nene Nair said, I totally agree. When we say we do not have the time, we need to make the time, even for a matter of 20 minutes. That's why I always tell in my shows that even if you do not have the time to go to the gym for some reason, right? You can do your own workouts even at home based. You can do your own sit-ups, you can even do your own step up just by lifting up your leg up and down for a period of 20 reps or 30 reps. It's also an exercise. So think about it, right? You can do everything within your home. Of course, if you can go to the gym, that will be perfect. But if you do not have the time for some reason, you can just walk around your neighborhood. And with health promotion board coming in with the 10,000 steps, I think it's a very beautiful tool that we all have to monitor. They are giving the signs, right? They're giving us the path, they're giving the symptoms. So we need to follow all that. What are the things that we need to do in terms of keeping ourselves healthy and fit? So no excuses, people. We all busy. I agree, we all busy, but we need to make the time. And I really thank Dr. Dinesh Nair for coming on board for the second time with Kopi Revenge to share. And I'm actually puzzled with all the new technology. That's why if you look at it, I'm actually silent all the way. I'm like become one of his student, but his understanding to understand this. It's the big thing, right? I always call doctors as angels, angels in a white coat, coming and saving people. Because without them, I think we humans will be probably in a deep problem. All right, so viewers, thank you so much again, for joining us. I know there's another message that came in from Indonesia. Probably we'll take that later. My Malay is not good. I'm so sorry. So yes, coming back tomorrow, we have another topic on home sweet home, or rather, you can tell it. Another guest speaker is coming in to talk about properties, housings, and kind of stuff that is supposed to be the lifestyle segment. So tune in, and I'm gonna catch you guys tomorrow again at 9 p.m. and I'll catch you. For now, adios, amigo. Bye bye.